Hey guys, it's Rich Gordon here. I'm going to be talking to you about practical ultrasound for the undifferentiated hypotensive patient. Now obviously I'm coming to you from the perspective of an emergency physician, but really what I'm going to talk to you about can be applied at the bedside on the wards, can be applied in the intensive care unit, can be applied in a resource limited setting. Generally anywhere where you care for the acutely ill. I think that this lecture can help you. The objectives, we're going to discuss an intuitive algorithm or an intuitive approach to ultrasounding the undifferentiated hypotensive patient. Hopefully I can convince you to pull ultrasound to the bedside early when you have that undifferentiated hypotensive patient before you. Now, if you look into the literature, there's a whole bunch of algorithms and acronyms for ultrasounding the undifferentiated hypotensive patient. The truth is I don't really want you memorizing any of this stuff. I don't want you memorizing some algorithm, some step 1, 2, 3, 4 approach. I want it to be something intuitive, because that's what's going to serve you the best when you're caring for someone who's acutely ill. And really, at the end of the day, all of these algorithms work around the same principle anyway. And that is a tank, a pump, and some pipes. All right? Now for us, the tank is going to be the inferior vena cava. The pump is going to be the heart, obviously. The pipes are going to be the aorta for the most part. Now, let's focus on the tank for a second. If you think about the difference between an artery and a vein, artery has that thick tunica media with a lot of elastance. It'll expand and immediately recoil to its original position. A vein, on the other hand, lacks that thick tunica media. It's more of a flimsy, highly compliant vessel. Right? So its diameter is going to vary a lot with small changes in pressure. So think about jugular venous distension. Think about a caput medusa. Or you can think about varicose veins, all high pressure situations where that vein dilates up and holds more volume. Now, if you look at a little pie chart here, which I've put in, the systemic veins and venules hold approximately 60% of our circulating blood volume. So that's why we call the IVC the tank. All right. How do you ultrasound the inferior vena cava? Well, you'll need one of the low-frequency probes. This could be the cardiac probe, also known as the phase array probe, or it could be the abdominal probe, also known as the curved linear probe. In this case here, we're using the phase array probe or cardiac probe. And the probe indicator is pointing towards the patient's head, which is positioned up here. And you're going to get a long axis shot, also known as a sagittal cut, through the liver, as shown right here. And you'll slide just to the right of the patient's midline. And you should see the inferior vena cava come into view right here. And you can see the hepatic vein that's going down into form the hepatic confluence, where the hepatic vein joins into the inferior vena cava, and you can see the right atrium right here. You may need to tilt this probe back just a little bit to look underneath the costal margin. Now, if you're having trouble identifying the IVC, in all likelihood, you probably answer your question. It's probably so small that you just can't see it, and it's a low circulating volume state. But if you're unsure still, you can try getting a subcostal view of the heart, and you'll identify your right atrium right here. You'll stand that probe up vertically, which will transition your view into this right here, where you can see the IVC. You can see all the hepatic veins coming in to form that hepatic confluence where they enter into the IVC. And then you turn the probe long axis, rotating on this image, which will give you this image here. Okay. Now, one of the pitfalls is going to be accidentally identifying the aorta over the inferior vena cava. If you pay close attention to the branches that are coming off of the vessels, then you'll be able to identify and differentiate one from the other. This is the aorta, and I know this because this is the celiac trunk, and this is the superior mesenteric artery. A lot of people will automatically identify the aorta because they'll say it's pulsatile. Well, both the IVC and the aorta are pulsatile, so you can't rely on that to differentiate one from the other. So here's a comparison. One is the IVC, one is the aorta. Well, I just showed you this picture and told you it was the aorta, but hopefully you're paying attention and see this is the celiac trunk and this is the SMA. In this case, you can see the IVC is entering into the right atrium, and we can see that hepatic vein coming down to form the hepatic confluence before it dumps into the IVC. Okay, so that's the IVC, and this is the aorta. Okay, so now that you know how to identify the inferior vena cava with ultrasound, let's talk about how to interpret that image as full or as an empty tank. Taking a look at this image right here, we have the inferior vena cava traversing the liver. Probe indicators pointing towards the patient's head, so the feet would be on this side of the screen. And as the patient breathes in, you can see the liver and the diaphragm go towards the patient's feet. What's going on, because this is a spontaneously breathing patient, generates a negative pressure in the thorax. This basically sucks the blood up through the IVC into the right atrium, as if you were sucking water through a straw. And just looking at the diameter here, you can see that it looks slit-like. It's kind of flat, and the internal walls of the vessel come in contact with one another when the patient breathes in. These are all consistent, this narrow diameter, this 100% collapsing IVC, all consistent with a low volume state. So this could be somebody who has a true hypovolemia, like a hemorrhage in a trauma patient, or it could be somebody who has sepsis, so it would be a relative hypovolemia, or a distributive shock would be another way to look at it. How about this one? In this case, again, we see that there is a thin slit-like IVC located right here, and when the subject breathes in, the walls come down and collapse on one another, consistent with a hypovolemic state. And how about this one right here? This IVC right here, again, slit-like, 100% collapsing in on itself when the subject takes a breath in. Again, consistent with an empty tank. And also, too, just looking at this, you can see this could be an IVC that would be really difficult to see when you're scanning and trying to identify that IVC. And this kind of reflects on my previous statement that sometimes if you can't find the IVC, you probably answered your question as to whether it's a full or a flat IVC. What else do we get from this image? Again, a low flow state or an empty tank. We know that this person doesn't have any downstream impedance to flow. So in the case of any obstructive shock or pump failure, you would expect a backup of blood, all right, a downstream impedance to forward flow. So we know this subject doesn't have a large central pulmonary embolus. We know that this subject doesn't have tamponade. We know that the subject doesn't have a tension pneumothorax. And we also feel pretty confident that this patient doesn't have pump failure. Okay, all four of these diagnoses would be an impedance to forward flow, and you would see a backup of blood back through the IVC. So we can feel pretty confident taking those four diagnoses off the table really early in the course of our patient's evaluation. In addition, we know that this patient needs large volume resuscitation. We can feel very comfortable up front asking our nursing colleagues to go ahead and prepare to give the patient 3, 4, 5 liters of fluid up front. This person has a very low circulating volume, either truly or relatively, as previously discussed. So let's talk about a full tank. All right, here's an example. You can see here we have a nice wide IVC, and we can see that when the subject takes a breath in, there's really no variability in the diameter. This would be effectively a 0% collapse IVC. How about this one? Again, we have our IVC right here, and we can see the subject taking breaths in. Not a lot of variability there. We can also see a nice large dilated hepatic vein as well. This would be consistent with a full tank. And how about this one? There's another IVC here. Essentially no variability, maybe a 5% variability with respirations. So again, consistent with a full tank. So once we've identified an IVC like this, we know right off the bat, pulmonary embolus, tamponade, tension pneumothorax, pump failure are all pretty high on our list. We know that this patient is less likely to be hypovolemic. Can't be completely sure of that, and I'll explain that here coming up. But we know pretty early on this patient is likely not hypovolemic. And we know that empiric large fluid loading might be harmful. So rather than saying, yeah, go ahead and give this patient 3 liters and we'll repeat the ultrasound and continue to do our evaluation and work up this patient, we'll say, let's go ahead and give a 500 cc bolus, see what the patient's blood pressure does, and continue our workup. So what do we do with the in-betweeners? The subjects whose IVC is not fully collapsible, the subjects whose IVC is not plethoric and resistant to collapse with respiration. What do we do with this subject right here? In this case, just looking at it, doing kind of a qualitative analysis, which is all you really need to do, I'm not an advocate of measuring the IVC and getting exact numbers. Just say and look at it and say it's approximately a 50% collapse with inspiration. What do we do with this IVC here? Well, if you look through the literature, Nagdev and colleagues in 2010 published a paper stating that in subjects whose IVC collapsed 50% or greater, that was consistent with a CVP that was less than 8. So you could say in this subject, in all likelihood, they have a lower circulating volume. Another study done in 2012 by Mueller and colleagues did a study not so much looking at comparing CVP to IVC collapse, rather they were looking at fluid responsiveness and IVC collapse. Fluid responsiveness meaning you get a fluid bolus, that increase in preload in turn increases your cardiac output or moves that patient up Starling's curve. And what they found was a 40% collapse, a 40% or more collapse correlated pretty well with someone who was fluid responsive. Did not mean that they were not fluid responsive if they had a collapse less than 40%, and I hinted at that earlier. But that's kind of the stance that I take on it. If they have a 40%, 30% collapse or more, I say that subject needs fluid. Now, at the end of the day, the IVC is not the end-all, be-all when it comes to deciding whether the patient needs fluid or not. If the IVC is full or plethoric, or they have a collapse that is less than 30%, I still give a 250 cc or maybe a 500 cc bolus and see what the patient's blood pressure does. In the next couple slides, I'm going to kind of show you why the IVC isn't the be-all, end-all when it comes to determining whether the patient needs fluid or not. I like to think of a river when it comes to the IVC. And I think that's the best way to illustrate it. Here we have a river that is flowing along and well confined within the edges of that river. Now, sometimes that river may flood and the water may extend beyond the margins of its shoreline. This would be consistent with a plethoric IVC. And there could be a few reasons that this would happen. It could be that there has been a lot of rain and the river is swollen because of that. It could be because the dam that's upstream of your river, they've opened all the floodgates and they've allowed more water to come into the river below. It could be that that dam upstream is actually busted and now you have more circulating water coming downstream, causing that river to swell. These are all synonymous with giving your patient intravenous fluids. You've expanded your circulating blood volume. But just because your IVC is plethoric and non-collapsible does not mean that you have a fully loaded tank. For example, it could also be that downstream they've built a dam or they've closed off the floodgates, so all the water is now backing up. This would be consistent with a pulmonary embolus or tension pneumothorax or pericardial tamponade or pump failure where there is an impedance to forward flow. So the blood is backing up through the IVC. Even though you look at that IVC and you say to yourself, look, they have a high circulating blood volume, they may actually have a low circulating blood volume, and in reality, there's just an impedance to forward flow. So the point I'm trying to make is at the end of the day, it's not really about circulating volume as much as it is about the pressure within the system. So if you look at a big plethoric IVC, they may have a low circulating blood volume in the face of a pulmonary embolus, which would give a dilated IVC. Our ultimate goals with the IVC, at the risk of being redundant, is to, one, try to narrow our differential diagnosis. I think ultrasound is going to get you a lot farther in narrowing your differential diagnosis than clinical exam alone. Two, we're using IVC ultrasound as a guide to our resuscitation. In an ideal world, we would give our patients just enough fluid to bring them to the plateau portion of the Starling curve without giving them so much that we're going to give them pulmonary edema and large volume third spacing. The available evidence today suggests that ultrasound is probably the best non-invasive tool for guiding your resuscitation. If you fill that IVC to a 30% collapse with inspiratory effort, then you are not going to hurt that patient in terms of overfilling the tank, in terms of contributing to ARDS, pulmonary edema, large volume third spacing. So up until this point, we've talked about patients who are spontaneously ventilating. Patients who take their own breath, they generate a negative intrathoracic pressure which pulls air into the lungs. Not only does negative intrathoracic pressure pull air into the lungs, it also sucks blood up into the thorax. Just like if you were drinking water or a Coke through a straw, you generate a negative pressure in the oropharynx which pulls that drink up into your mouth. In exhalation, the IVC is at its largest diameter. Here the patient takes a breath in, the diaphragm and the liver go down towards the feet, narrowing the IVC. In the case of positive pressure ventilation, the IVC is at its smallest diameter in exhalation. As a positive pressure breath is delivered, the liver and diaphragm descend down just as if you were breathing spontaneously, but that positive pressure here provides an impedance to forward flow. It's actually going to dilate the IVC. So effectively, your physiology is reversed. Turns out the best evidence available for IVC ultrasound is actually in the mechanically ventilated patient when it comes to fluid responsiveness. And here are the three main studies that are most widely cited. Each of them are very small studies. Each of them have multiple problems with the way that they measured the IVC, and all of them had patients who were completely synchronous with the mechanical ventilator. In other words, they were deeply sedated or paralyzed and they were not breathing over the vent. They also, in all three studies, used tidal volumes that were a little bit higher than what we use today. We usually use tidal volumes around 6 cc's per kg. In these studies, they were trending towards more 10 cc's per kg. Nonetheless, each of them found around 15% dilation with a delivered breath with a ventilator, correlated quite well with fluid responsiveness. And 15% increase in the caval index is a very widely accepted threshold for fluid responsiveness in the mechanically ventilated patient. The last point I want to make before we move on to the pump is that the respirophasic changes in the IVC diameter really have to be used within the clinical context. Over the years, doing workshops and scanning on models who have absolutely no complaints and are physically fine, we've seen plenty of IVCs that were slit-like and 100% collapsing. Certainly doesn't mean that patient needs to be rushed off to the emergency department and given large volume resuscitation. So you use these findings within the clinical context. If you see a person who's coming in with vomiting and has a history of heart failure and you want to determine if you can give this patient fluid or not, go ahead and take a look at their IVC. If their IVC is nice and collapsing, you can feel comfortable giving that patient a liter of fluid and reevaluating. So it has to ultimately be used within the clinical context of your case. Just because it's collapsing doesn't mean that patient is critically ill. Just because it's full doesn't mean that patient is critically ill. Just because the IVC is full doesn't mean that the patient is not fluid tolerant or fluid responsiveness. You just use the ultrasound as a guide for your differential diagnosis and a guide for the resuscitation of your patient. Once I've evaluated the IVC, I usually advance on to the heart, particularly if the IVC is plethoric. So let's talk about the pump now. And really, when we're talking about evaluating the pump, we're not talking about a comprehensive echocardiographic evaluation. We're talking about three simple questions. And that is there fluid around the heart? Are the ventricles proportional? And is the ejection fraction normal? Now, with evaluating the pump, there's multiple windows to accomplish this. I recommend a 2-window analysis. Which windows you use is ultimately your personal preference. I'll just tell you now how I play it. Usually I start off with the parasternal long axis view. This gives you a really good evaluation of the left ventricle, and it gives you probably the best evaluation for a pericardial effusion, which I'll explain here in just a minute. With regards to the parasternal long axis view, you're going to be using the phased array probe, also known as the cardiac probe. I think this is the best probe to use when evaluating the heart because it has a small footprint and it can allow you to look in between the ribs through the intercostal spaces. The probe indicator is going to be pointing towards the patient's right shoulder with the probe indicator on the screen going towards the right-hand side of the screen. Okay, so This would be the standard cardiac orientation. Usually your machine will default to cardiac orientation when you select the phased array probe. So this would be a surface map of what it would look like. You would be scanning basically along the septum with that probe indicator again pointing towards the patient's right shoulder. You can see from this angle you get a little bit of the right ventricle, and mostly the left ventricle is what you'll be looking through. So this is what it looks like. Again, here is going to be right ventricle, interventricular septum, left ventricle. Here is the left atrium, mitral valve. This is the aortic outflow tract. Here's the aortic valve. And here's the ascending thoracic aorta. Looking posterior, this is the descending thoracic aorta here. This bright white line here is going to be the pericardium. Next view I like to use is the apical 4-chamber view. And this is how you obtain the 4-chamber view. The probe is placed just below the left nipple with the indicator pointing somewhere between the bed and the patient's left axilla. If you look at it from this angle, you'll see the sound beam intersects the ventricles this orientation, so you get a nice view of the right ventricle and the left ventricle. This would be the right atrium, and this is the left atrium. This would be the mitral valve here, and here's the tricuspid valve. This is the view that you should get. Again, left ventricle, right atrium, left atrium. Another view that is often used by emergency physicians, particularly those with not a lot of experience in echocardiography, is the plain old subcostal 4-chamber view, and this is a fine view to use. Basically, the probe is going to be placed in just below the xiphoid process with the probe indicator pointing to the patient's left. You'll get a view looking up through the RV to the LV, and looking laterally, this would be the perspective that the probe would have, looking through the right ventricle to the left ventricle. Here's the actual image associated with that. You're looking through the liver to the right ventricle to the left ventricle. This bright white line here would be the pericardium, and you can also see the pericardium here. Here would be an example of the subcostal 4-chamber view. Right ventricle, left atrium, right atrium. Here's the liver here. Now, if you want a detailed presentation on the different cardiac windows, you can visit eusacademy.com and follow these steps here. Go to the Ultrasound and Medical Student Education option, scroll to the bottom of the page and click on the heart, and you can get a detailed presentation on the various windows of the heart. So we're asking the question, is there fluid around the heart? Well, fluid on ultrasound appears black, and you can see here this is blood. Okay, so their ultrasound cannot differentiate between one fluid to the next. So blood looks just the same as ascites, just the same as urine, just the same as a pleural effusion, just the same as a pericardial effusion. It's all the same. Fluid is black. So what we're looking for is a black stripe between the epicardium and the pericardium, a black stripe in here. That'll tell you if there is a pericardial effusion. So let's take a look here. Is there a pericardial effusion? I just explained you're going to be looking for a black stripe going between the epicardium and the pericardium. And you can see that fluid dissects all the way back between the left atrium and the descending thoracic aorta. This is definitely a pericardial effusion. If you ever see this fluid dissect anterior to the descending thoracic aorta, that's actually a pleural effusion. So this is why I like this view so much to start out to look for pericardial effusions, because you can differentiate a pleural effusion from a pericardial effusion pretty easily. In the other windows, it's a little more complicated. So how about this one? Is there a pericardial effusion? Well, you can see right here, there's a pericardium, this bright white line. It goes off the screen here and then comes back around. Here's pericardium. I don't see a black stripe there. Overall, no pericardial effusion. Just for a quick review, do you know what window this is? We can see the liver here, and then we can see the right ventricle and then the left ventricle. So this would be a subcostal window or a subcostal 4-chamber view. How about this image? Is there a pericardial effusion? Well, you can see the pericardium here, extending all the way around, going slightly off the screen, and then coming back around here. And we can see a black stripe here consistent with fluid. So in this case, the patient does have a pericardial effusion that is clearly seen on a subcostal 4-chamber view. Again, here's the liver that we're looking through to the right ventricle and the left ventricle. In the case of the undifferentiated hypotensive patient, we may find a pericardial effusion, but is that the reason that the patient is hemodynamically unstable? Is it actually a pericardial tamponade? Now, the textbook echocardiographic criteria for tamponade can be easily missed. In this image, you can see the earliest echocardiographic finding, and that is collapse of the right atrium during atrial diastole. In this image, we can see collapse of the right ventricle during ventricular diastole. Specifically, this image is a parasternal long axis view, and you can see it almost looks like somebody is jumping on the ventricle. Again, very easy to miss. Now, this is another parasternal long axis view. In this case, the sonographer is not using standard cardiac orientation and using a reverse orientation, sometimes considered the emergency orientation. Nonetheless, it's a parasternal long axis view. You can see that bowing of the right ventricular free wall when the patient breathes out. So there's a decrease in right ventricular preload, and that change in pressure allows that right ventricular free wall to bow in. Again, extremely easy to miss. Here's a late finding of pericardial tamponade. You can see that the right ventricle is collapsed through systole and diastole. When they pan to look long axis on the IVC, you can see that the IVC is dilated and there is no respirophasic change, which is consistent with an obstructive shock seen in pericardial tamponade. Ultimately, don't forget that tamponade physiology depends on the rate at which the fluid accumulates. I want you to resist the temptation to diagnose pericardial tamponade based on the size of the effusion. Take a look at this pericardial effusion. Can we determine that this patient has pericardial tamponade? The answer is no. We can't determine that this patient has tamponade. Certainly has a large pericardial effusion. Looking at the free wall of the right ventricle, I don't see any collapse of the right ventricular free wall on this case, but it's not a complete evaluation. The point I'm trying to make is it's certainly a large pericardial effusion. It does not mean this patient has pericardial tamponade. Just kind of an afterthought, you can see here echocardiographically the reason for electrical alternans with large pericardial effusions. This patient has such a large pericardial effusion that the apex of the heart is actually oscillating with each beat of the heart. So there's beat-to-beat variation in the position of the heart. So effectively, you're having a change in axis of the heart, which is going to give you a change in axis of your QRS complex. So what I recommend is if you have a large pericardial effusion, consider the tank. Now, we can see here, this is a subcostal 4-chamber view of the heart. It's a little bit grainy, not the best image available, but we see a large pericardial effusion. Looks concerning for pericardial tamponade, but there's our IVC. And our IVC is completely collapsing. This is not pericardial tamponade, and that's what I encourage you to do. If you see a pericardial effusion, big or small, consider what the IVC is doing. If the IVC is big and plethoric, I want you to treat it like pericardial tamponade. If the IVC is small, collapsing, this is not pericardial tamponade. Now, if on the other hand, your IVC looks like this, in comparison with the previous image, a large pericardial effusion, this is a non-collapsible, large plethoric IVC. I want you to treat this patient as if they have tamponade. This patient needs a pericardiocentesis. So in summary, circumferential pericardial effusion with dilated, non-collapsible IVC, we're going to treat it as pericardial tamponade. We're not going to spend time looking for right atrial diastolic collapse. We're not going to spend time looking for right ventricular diastolic collapse. We're going to go ahead and call a pericardiocentesis tray to the bedside. We're going to mobilize our consultants or our transport services if we're unable to provide that service at our center, and go ahead and treat this patient as pericardial tamponade. So the second question that we're asking is, are the chambers proportional? The normal left to right ventricular ratio is 1 to 0.5. So looking at this image, are the ventricles proportional? Well, the right ventricle looks approximately half the size of the left ventricle, so I would say yes. How about this case? Well, here we can see that the right ventricle is a lot larger than the left ventricle. So clearly in this case, the ventricles are not proportional. How about this case? Here's our left ventricle. Here's our right ventricle. It's important to point out the endocardial border here. We're not talking about the chamber including the walls or the wall thickness, just the chamber size. Comparing the chamber size of the left ventricle to the right ventricle is about as large as the left ventricle, so they're not proportional. How about this case? Here again, we can see clearly that the right ventricle is a lot larger than the left ventricle. So what does this all mean? What does a right ventricle that's larger than a left ventricle mean? Well, obviously you get concerned that this could be a pulmonary embolus. Now, does a right ventricle larger than a left ventricle mean the patient has a pulmonary embolus? Not necessarily. This is where clinical context comes into play. If you have a patient who just flew in from overseas or just had a transatlantic flight and they come in hypoxic and short of breath and hypotensive, and you see this on your echo, then yes, this patient most likely has a pulmonary embolus, and you should feel comfortable giving this patient thrombolysis. Now, the third question we ask, is the ejection fraction normal? Well, I recommend using a subjective qualitative estimation technique. We don't need to know the exact percentage of the ejection fraction. We're not doing a comprehensive echocardiographic exam. We're not managing chronic stable heart failure. I would challenge that a ejection fraction of 50% and 60% is going to have very little clinical relevance to you at the bedside. However, an ejection fraction of 25% versus an ejection fraction of 85% will have clinical relevance to you. So it's the extremes of values that we really care about. Now here's a study comparing cardiologists to ED investigators, and you can see that there was a 70.37% agreement with a poor ejection fraction and a 92% agreement with a normal ejection fraction. So overall, the extremes, which is what we care about, there was high agreement between the cardiologist and the ED investigator. And they were just using a simple qualitative technique. Here's another study, again, comparing emergency physician to cardiologist. In extremes, there was a very good agreement, 84%, using a qualitative assessment. Overall, I recommend not worrying with documenting the exact numerical value. Just say hyperdynamic, normal, mild to moderately depressed, or severely depressed. So here you can see what I've listed. Hyperdynamic would be 70% ejection fraction or better. Normal would be 50 to 70%. Mild to moderately depressed would be 30 to 50%. And severely depressed would be less than 30%. Again, the values we really care about are hyperdynamic and severely depressed. So let's do a qualitative assessment on this patient. And how do we do it? Well, what you're looking at is the difference between your end diastolic volume and your end systolic volume. All right. So I've frozen the two images here, and I've mapped it out for you. This is end diastolic volume, and this is end systolic volume. So if you overlay these, there's approximately a 50% change in volume. So this is a roughly 50% ejection fraction. If I'm off a little bit, it really doesn't matter clinically. So let's compare this one, which we've already determined, which is a normal ejection fraction, to this one. You can see the difference between your end diastolic and end systolic volumes are a lot less than the normal ejection fraction. So I would classify this as a moderately to severe depressed ejection fraction. Here's normal. And here's your abnormal. Let's compare normal again to this ejection fraction. This is a subcostal 4-chamber view. Here's your left ventricle. Look at the difference between your end diastolic and your end systolic volumes. There's essentially no difference. This patient has a severely depressed ejection fraction. Now let's compare this image, again, our normal ejection fraction, to this image. Here's our left ventricle. Now in this case, we were attempting to do an apical 4-chamber view, but because of the patient's position, we just couldn't get a good view. But you can see the difference between your end diastolic and end systolic volumes. You can see that the endocardial borders of the left ventricle are actually kissing. This would be a 100% or near 100% ejection fraction. You could just say a hyperdynamic left ventricle. So here's a comparison side by side. We have normal, hyperdynamic. Well, why do we care about ejection fraction? In the case of the hyperdynamic LV, as pictured here, this patient clearly needs more preload because their end diastolic volumes are so low. Now, if this patient has a pulmonary embolus that is obstructing blood flow from the right ventricle to the left ventricle, obviously they need lysis. If this is a patient who you've already given 3 or 4 liters of fluid to and the IVC is starting to plummet up, but you take a look at the LV and it's still hyperdynamic as pictured here, then this patient needs more volume. I would continue IV hydration. Now in this case, we have a severely depressed ejection fraction. Let's say you've given a 250 cc bolus of fluid and their blood pressure has not increased. Now you have to consider inotropic therapy because you need to improve this patient's cardiac output. You need to improve this patient's ejection fraction. And the way to do this, as opposed to fluid therapy or purely vasopressor therapy, you also need to add inotropic therapy to improve this patient's cardiac output. Now, one part I'd like to add here at this juncture is an evaluation for pneumothorax. Now, on your differential diagnosis for obstructive shock is tension pneumothorax. Now, in this case, you would expect a dilated IVC and a hyperdynamic LV. But in reality, you're probably not going to be able to see the heart at all. Because of the air that fills the thorax, ultrasound waves don't travel well through air, so in all likelihood you won't be able to see the heart. If you notice that you're having trouble getting a good image of the heart and the clinical scenario fits, you should have a high index of suspicion for pneumothorax. Now there's nothing wrong with empiric bilateral needle decompression when the clinical scenario strongly suggests tension pneumothorax. But still, there's no guarantee that there's a pneumothorax. But one thing you guarantee is if you do a needle decompression, then you need to follow that up with chest tubes. In addition, if you do needle decompression of the thorax, there's some good evidence out there that shows that you may not actually enter the thorax because some people have a thick chest wall. So you may stick that needle in the second intercostal space, mid-clavicular line, get no rush of air, and assume there's no pneumothorax, when in reality, the needle never pierced the thorax to begin with. I prefer just to do a quick ultrasound assessment, and the sensitivity to pneumothorax in a supine patient with ultrasound is 98%. And overall, this is a very quick assessment. It's really not going to take a lot of time. In fact, I bet that in the amount of time it takes you to go find a 14-gauge angiocath, you could do a bilateral thorax assessment for pneumothorax. So how do we do it? Well, the ultrasound probe is going to be placed in the most anterior portion of the thorax. And you can use any of the probes. You can use a low frequency or you can use a high frequency probe. It doesn't matter. In this case, we're using a high frequency probe because it just gives a better detailed image for me to explain this to you. So what you'll see is a rib. This is the intercostal muscle, and this is the interface between the visceral and parietal pleura. As a patient breathes, the visceral and parietal pleura slide past one another. If you see this shimmering, or what they call ants marching in a line here, then you know this patient does not have a pneumothorax at that position. If you're worried about a tension pneumothorax, obviously they don't have a tension pneumothorax. So you'd quickly shift over to the other side, as shown here. Again, the most anterior portion of the thorax. Here's our rib. Here's the intercostal muscles. Here's the visceral and parietal pleura interface. And as the patient breathes, you can see the visceral and parietal pleura sliding past one another. Now, here's another case. Let's say here we are ultrasound in the right lung. Here's a rib. Here's a rib. I don't see that visceral and parietal pleura sliding past one another. I don't see that ants marching in a line sign that we mentioned earlier compared to here. Okay, this is very concerning for pneumothorax. If the patient is intubated, then this could be a main stem intubation. There could be a mucus plug. This patient could have COPD. These would be other reasons for loss of a sliding lung sign. However, if you're concerned clinically this patient could have a pneumothorax and you identify this on the left and this on the right, this is the side that you need to needle decompress and put a chest tube in. So, To be able to 100% rule in pneumothorax, you need to be able to identify a lung point. As you well know, air is going to go to the least dependent portion of the chest. And here the lung is compressed in the dependent portion of the chest. If you slide the probe around laterally, you'll eventually get to a point where the visceral pleura and the parietal pleura are in contact with one another. And what you'll see is a lung point. You can see where the normal visceral parietal pleura interface is. You can see where the parietal pleura here is not in contact with that visceral pleura. So as the patient breathes and that lung inflates and deflates, you'll see that very edge of the pneumothorax come in and out of view. This 100% rules in pneumothorax. Now, in a patient who is hemodynamically unstable and you're contemplating doing a needle decompression and chest tube, I don't think you should be wasting any time trying to find the lung point. If you can find which side has the loss of a sliding lung, then that's the side you need to decompress. If you see a sliding lung sign bilaterally, you have ruled out tension pneumothorax and you can move on in your algorithm and in your efforts to determine what the etiology is of this patient's instability. Starting back up at the beginning, when we're doing our initial evaluation of the tank, if I discover that the tank is low or we have a low circulating volume, I usually don't go straight to the pump. I instead go to do an evaluation of the pipes. All right, and specifically, we're looking for evidence of a leak. Some reason this patient is hypovolemic. Now, looking in this room here, we can tell that there's clearly a leak. This person's home clearly has a leaky pipe. We know that because water is to collect in dependent areas of all of these rooms. And effectively, that's what we're doing in this sequence. We're looking for evidence of a leaky pipe. Now, the aorta would be the water main. However, you have to bear in mind there's numerous vessels that could spring a leak in the peritoneal cavity. So really, it comes down to clinical context. If you have a ruptured aorta, this is likely going to be a contained hemorrhage. So this will be a retroperitoneal hemorrhage. Most of the time, you're not going to be able to find free fluid in a person with a ruptured AAA. However, if you have a person who has a ruptured ectopic pregnancy, there's a good likelihood that you would be able to find free peritoneal fluid. So really, it comes down to your clinical gestalt. You have to ask yourself, do you have a high suspicion for a ruptured AAA? Is this a 70-year-old man who has a heavy smoking history, who complained of back pain and then went unconscious, versus a 19-year-old girl who missed a period and went unconscious? It really comes down to that clinical gestalt, and that's what's going to determine what your next course of action. It goes back to an early slide in this presentation. It's going to be an intuitive approach. If AAA is lower on your differential diagnosis, I recommend starting out with a routine scan of the abdomen or performing a FAST exam. So we're going to just search the dependent areas of the peritoneal cavity. And if you go along with that picture that I showed you just a moment ago of the water all throughout this person's house, and you consider that clientele versus plumber metaphor, as emergency physicians or as the acute care physicians, we are effectively serving as the clientele, and the surgeon will be the plumber. It's our job to find evidence of that leak and then call the surgeon who could come in and fix it. We don't really care so much about exactly where that leak is coming from unless it's a AAA. Now, what I'm getting at here is to perform a FAST exam. Now, a detailed discussion on FAST exam is beyond the scope of this talk, but I'll just review it quickly. This FAST exam starts with the ultrasound probe placed in a sagittal position in the right flank, and you'll get a view of Morrison's pouch as well as the space above the diaphragm, and you're looking for a black stripe either in Morrison's pouch off the inferior pole of the kidney or just above the diaphragm. This is a normal image with no free fluid. This is a FAST positive exam. You can see this black stripe here. This would be evidence of hemoperitoneum. You then progress over to the left upper quadrant where the probe is effectively placed in the left flank. You'll get an image of the spleen. Here's the diaphragm. Here's the splenorenal recess. And you would also want to move the probe down towards the patient's feet to look off the inferior pole of the kidney to check the left pericolic gutter. If you see a black stripe in any of these locations, then you have evidence of hemoperitoneum. Here's a positive finding. Here's the spleen, here's the diaphragm, here is free fluid in the diaphragm and the spleen. This would be a FAST positive case. Next we move to the pelvic region, and we are going to scan through the bladder And you can see here the bladder is full of urine, and looking posterior to the bladder in the pouch of Douglas, we don't see any free fluid. Comparing this with an image shown here, this would be fast positive. You can see free fluid is collected posterior to the bladder. Is there significant bleeding? So if you have a patient who presents to you hypotensive and the cause for their hypotension is a hemoperitoneum, then studies show in all likelihood you're going to be able to detect that. In this study done by Rosecki in 1998, they had 1,227 blunt trauma patients. Of this cohort, the ones that were hypotensive and had hemoperitoneum, the sensitivity and specificity was 100% for detection of hemoperitoneum. So what I'm trying to say is if the person is bleeding in the abdomen and this is the reason that they're hypotensive, in all likelihood you're going to be able to see it on a fast exam. Now, on the other hand, if your clinical suspicion is much higher for a ruptured AAA, I recommend you forego a fast exam and instead proceed directly from IVC to an evaluation for AAA. Now, this should be a very rapid evaluation for abdominal aortic aneurysm. I'm going to show you how quick it should be here in just 1 second. Now, a ruptured AAA is going to be a contained hemorrhage within the retroperitoneum. And as I've already said, the ultrasound is not a great tool for screening the retroperitoneum for free fluid. Basically what you're doing is you're looking for a AAA. If there is a AAA in a patient who you have a high clinical suspicion for ruptured AAA, you assume AAA and you call the vascular surgeon. An aorta is considered aneurysmal if it's greater than 3 centimeters in diameter. The likelihood of rupture goes to 3 to 15% annual risk when greater than 5.5 centimeters. Now, that does not necessarily mean that it has to be 5.5 centimeters to rupture. Again, you have to use that clinical gestalt. If you find a 4.8 centimeter aneurysm and you have a high suspicion that it's a ruptured AAA, you still assume ruptured AAA and call vascular surgery while you continue resuscitation. So how do we do an aorta sweep? Well, we start with a low-frequency probe in the transverse or horizontal position in the subxiphoid region. So the probe is stood up vertically. You're going to then try to identify the anterior cortex of the vertebral body. The anterior cortex of the vertebral body is your landmark to help you identify the aorta, which will be just to the patient's left or screen right of the anterior cortex of the vertebral body. So that's how you know for sure that you're looking at the abdominal aorta. One last time. Right here, aorta, we're sweeping down towards the umbilicus, all the way to the bifurcation. And we're going to sweep rapidly, not taking any measurements. You don't have to do any measurements. You could see that that was clearly a normal caliber aorta. You've ruled out AAA with that exam right there. Now, if on the other hand you see this, this is an abdominal aortic aneurysm. In a hypotensive, unstable patient who your gestalt is high for ruptured AAA, this is AAA. You assume it's ruptured. We don't see any free fluid. We don't care about that. This is in all likelihood a ruptured AAA. You call vascular surgery. This here is showing how to measure a AAA. I think it is helpful to at least go ahead and measure this so you can relay this to your surgical colleagues. Detailed discussion on evaluating AAA is beyond the scope of this presentation, but suffice it to say, the calipers are measured from outside wall to outside wall. Now at this point we've covered a lot, so I want to review this with you before I give you a couple of cases just to test what you've learned. So this is the whole algorithm that we've covered. So let's review this now. We have an undifferentiated hypotensive patient. I recommend you start off with IVC ultrasound, and you're going to determine whether that IVC is flat and highly collapsible or it's plethoric and non-collapsible. And once you've determined that, let's assume that it is flat and highly collapsible. You're going to ask yourself, do you have a high clinical suspicion for AAA? If you do, then you're going to proceed to a AAA scan. If not, you're going to proceed to a fast exam. Aorta scan shows a AAA, you consult vascular surgery immediately. Again, not worried about whether we see free fluid in the retroperitoneum. However, if our suspicion is low for a ruptured AAA, I recommend proceeding directly to fast exam. If the fast exam negative, then your suspicion turns to pathology such as sepsis, GI bleed, Was it bleeding outside of the peritoneum? Is this hypovolemia just from vomiting and diarrhea? If the FAST exam is positive, you have to ask yourself, is this patient pregnant? Has there been any trauma in the history? Could this just be ascites? As I mentioned earlier, we can't differentiate one fluid from another. Free fluid is free fluid, so you have to use your clinical context. Depending upon what your clinical context is, you consult GYN or you consult surgery. If you think it might be ascites and the patient is stable enough, you can do a quick peritoneal tap. If you get frank blood out, you know you need to call surgery. If it's ascites, then you have to keep looking. Now, on the other hand, going back towards the top, if our IVC is plethoric and non-collapsible, I recommend going forward to echocardiography. And if you note that you have a dilated RV with a hyperdynamic LV, this is strongly suggestive of pulmonary embolus. If you have a severely depressed ejection fraction, that suggests cardiogenic shock. You need to go ahead and get inotropes on board, as well as your fluid resuscitation and as well as vasopressors. If there's a circumferential pericardial effusion with a hyperdynamic LV, in addition to a plethoric non-collapsible IVC, then you assume pericardial tamponade. You go ahead and pull a pericardiocentesis tray to the bedside and go ahead and mobilize consultation versus transport to a facility that can provide pericardiocentesis. Now, another consideration, if the heart is not visible or there's hyperdynamic ventricles bilateral in addition to a plethoric non-collapsible IVC, could this patient have a tension pneumothorax? Just do a quick bedside evaluation for pneumothorax with your ultrasound. Is there sliding lung sign bilateral? You've taken pneumothorax off the table. If there's a loss of sliding lung sign on one side or the other, then you can assume tension pneumothorax and quite confidently proceed to needle decompression. Okay, so let's do some practice cases. Each one of these cases, and I'm going to give you 3, are real cases from our department. So case 1. This is a 55-year-old woman with a history of diabetes and end-stage renal disease. She's referred to the hospital for amputation of a gangrenous right great toe. Vital signs are within normal limits at presentation, and a physical exam shows a right great toe black in appearance with some purulence at the base of the toe and mild local erythema extending proximal. There's no crepitus. The labs are consistent with a poorly controlled diabetes history as well as a known history of end-stage renal disease. X-ray of the right foot shows no gas and no periosteal reaction. Blood cultures are taken, antibiotics initiated, and admitted to the medicine service with orthopedic consultation. Now, nurse approaches you with a blood pressure that has trended to 80/60. Patient is sleeping but arousable and has no complaints. BP is 88/65 despite a 1.5 liter bolus and rapid aliquots of 500 mLs. So obviously at this point we have a blood pressure that's not really responsive to the fluid boluses that were given. So we call ultrasound to the bedside, and we're going to start off with undifferentiated hypotension scan, and we're performing an IVC ultrasound. All right, and clearly you can see there that we have a plethoric non-collapsible IVC. So where do you want to go from here? Well, I recommend you take a look at the heart. Could this be an obstructive shock of some sort? So this is what we did. Now we have a circumferential pericardial effusion with a plethoric non-collapsible IVC. We continue 250 ml aliquot boluses. Pericardiocentesis tray was brought to the bedside. Cardiology echo requested, and they agreed this was consistent with tamponade. Patient was taken emergently for pericardiocentesis under fluoroscopic guidance, and BP responded to drainage of the pericardium. Patient had an uneventful hospital stay thereafter. So case number 2. This is a 58-year-old man with no known medical problems, presents with right upper quadrant abdominal pain. The pain was sudden onset, sharp, and radiates around the right chest. It woke him from sleep. Never has experienced this pain before. States it hurts to breathe. No other associated symptoms. Vital signs shows a blood pressure of 90/60 with a heart rate of 122, respiratory is 28, and temperature is 38.0. Now the patient is pale in appearance, and his tachypnea is exquisitely tender in the right upper quadrant to deep palpation, which creates the exact pain the patient complains of. Initial concern was sepsis secondary to cholecystitis. Ultrasound was brought to the bedside. to assess for evidence of cholecystitis. While looking for the gallbladder, this is what we saw. So here you can see a plethoric non-collapsible IVC. Could this be an obstructive shock case? Now we have a subcostal window, 4-chamber view of the heart. And here, if you look very carefully, this is the endocardial borders. It's a tiny left ventricle that's hyperdynamic with a right ventricle that is significantly larger than that left ventricle, and also a grossly dilated right atrium. And also you can see, if you look very carefully, you can see a bowing of the septum into the LV cavity as the patient inhales, suggesting severe elevated right heart pressures. So ultrasound was interpreted as very concerning for pulmonary embolism. Patient began rapid progression into a state of shock. Patient was intubated and TPA was administered, followed by vasopressor support. On hospital day 3, the patient died of complications related to the massive pulmonary embolus, which was later confirmed. Case number 3, this is a 65-year-old woman with a history of cervical cancer, end-stage renal disease, and hypertension. She has good compliance with her dialysis regimen. Family reports she had not been herself for the last 1 day. She has had poor PO intake. Patient can provide no further history due to the medical condition. Blood pressure is 75/45 with a heart rate of 140, respiratory is 25, temperature is 35.5, and a pulse oximetry of 92% on room air. Physical exam is remarkable for somnolence, cachectic appearance, dry mucous membranes, crackles on the right base, cool skin with a decreased cap refill. Now, chest x-ray is consistent with right middle and right lower lobe pneumonia. Labs were remarkable for leukopenia, chronic renal failure, and a lactic acid of 4. Patient was cultured and broad-spec antibiotics were initiated. 2-liter bolus was given over 30 minutes. Now, after this, the blood pressure was 80/50. And the resident expressed concern about administering further fluid boluses given the end-stage renal disease and wants to start vasopressors. Instead, we went ahead and brought ultrasound just to do a quick hypotension assessment, starting with our ultrasound of the IVC. This is what we saw. Here's our IVC here. You can see that it is thin and 100% collapsible with inhalation. This is interpreted overall as a low volume state. We did proceed with an aorta scan as well as a FAST exam, both of which were negative. We decided to continue intravenous hydration, so the patient got 4 liters total. Here's a repeat scan of the IVC. You can see now it's collapsing roughly 40%, 50%, somewhere in that neighborhood. Ultimately, we gave 1 more liter. The blood pressure stabilized at 115/75, and a lactic acid cleared to 2. So overall, the patient got 5 liters of fluid. The mental status was much improved after our therapies. So just to show the progression, this was the IVC at maximum inhalation after 2 liters. Here is the IVC at maximum inhalation after 5 liters. Let's take a look at the heart, by the way. We did do an evaluation of the heart. You can see here, this is a near 100% ejection fraction. It would suffice it to say hyperdynamic LV. Here's the heart after 5 liters. This is the same patient. You can see the end diastolic volumes are much better. Ejection fraction is within normal limits. So the conclusion, patient was admitted to the hospital floor with a final diagnosis of severe sepsis secondary to pneumonia. Patient had an uneventful hospital stay and was discharged 4 days later. So I hope you enjoyed this presentation on ultrasound applications for undifferentiated hypotensive patient. I hope you learned a good bit as well. I think that if you choose to apply this at the bedside of your future patients, whatever career track you ultimately go with, I think that it'll serve you well. Don't hesitate to shoot emails to me if you have any questions. We'll see you guys around.